Hi everyone, it's Clay Ferris with MostMedicaid.com bringing you the Medicaid news from our wonderful Medicaid world for June 19th, 2026. Happy Friday, happy Friday, happy Friday. As always, I'll do the Medicaid news recap. We'll give you a preview of what's in your intel packs and Job Hunter, and we'll talk about acronym of the day, and we'll do Mission Possible. Don't forget, you can get your copy of the intel report in your LinkedIn peer group. Look up on the screen to find yours. We've got peer groups for community plan workers, for pharmacy and DME professionals, for HHS staff, state, local, and federal government, and for solution providers. So look for the weekly intel briefs that we're dropping in that. So not only will you see the news stories in there that I'm walking through and kind of you can follow along if you're interested in that, or if you want to dive deeper in what you're hearing out in the show today. I usually call out the numbers themselves. Not only will you see that kind of stuff, you'll see the Job Hunter information, you'll see the acronym of the day infographic, you'll also see things like crosswords, and you'll get the cover art. This week's cover art, we've been doing House of Cards, that Medicaid is a house of cards. This week's cover art is the Seven of Spades. That's the governor. You can see that up on the screen. I haven't had a lot of time to get discussion on these. I had been doing that. I'm going to try to get back to doing that as soon as I can. I'm doing a lot of other stuff here at Most Medicaid. But governor is Seven of Spades. Don't forget, spades is the most powerful suit in the deck. You can kind of see my thoughts on who the puppeteers are of the governor if you're looking up here on the screen. But for now, let's hop into the Medicaid news. We'll start out with MCO news. Our first item in our intel report is state prosecutors accuse United Healthcare of a $100 million fraud scheme. So we covered this a little bit the last few weeks, but more details are coming out. And as always, we just want to make sure that everyone knows the shenanigans that the empire is up to. If you missed it, Massachusetts is suing United Healthcare, saying that it inflated Medicaid patient needs assessments with a bunch of HRAs, health risk assessments, to get $100 million more than United really needed to pay for their care. Some of the things that are new to me in terms of facts and tidbits this week is that United was identifying members as having mental health disorders, despite never having received a related diagnosis or treatment. There's also a little bit more information on who knew what when. And we already knew that United knew back in 2018 that this was going on. We find out now that they then reclassified, when they found out, they reclassified the needs of those members. So I guess corrected that for the ones who've been overstated, but never told the state about it. Of course, that probably would have required paying some money, some retroactive payments. So as long as United keeps on scamming, we're going to keep on reporting about it. We'll see if we have any new details next week. Oh, looky, here's another scam story that almost certainly involves United Healthcare. Let's turn to item 3 in your intel report. This is OIG focuses on prevention in new Medicare Advantage risk adjustment report. So this is the story we picked up, I think last week. There's an IG audit. It had some findings about acute stroke diagnosis and a sample of Medicare Advantage claims that they looked at in 2021. So the claims were in 2021. The problem is that these are really unsupported diagnoses. They only show up in, say, physician records, but didn't find a corresponding hospital admission or ER. Get into a little more details on this. They looked at 97 sampled enrollees, so the claims for 97 members, the Medicare Advantage members, and then extrapolated that out to about $462 million in potential overpayments in 2021. The study is interesting because it looks at diagnosis across plans as the unit of analysis. So it's really using the member as a unit of analysis instead of looking at any one plan over diagnosing behavior. And it looks at one diagnosis. And to me, that probably makes it even more credible when the data analyst in me thinks about this. Because if you see something happening in one single specific diagnosis code, that's probably because some revenue cycle management consultant says, hey, everybody hit that button over and over and over again. Put another way, if you see something happening in one diagnosis code, that's because somebody has shown them the way to game the system using that one diagnosis code. OIG is not recommending that CMS pursue the overpayments in this case, but instead to implement better prepayment controls. It's important to know that this diagnosis, this code for acute stroke, is actually flagged as high risk of miscoding. So we expected this result going into the study. It's just validating those expectations. And I think one last thought on this case, it's probably an example of both the provider and the health plan benefiting from inaccuracies in the data. Let's move on to tech news for this week. First up in tech news will be item 4 in your Intel report. Azara Healthcare acquires Advocacia to help safety net providers maintain Medicaid coverage. As always, folks, remember this is just a press release intended to get investors excited about a pretty lazy exploitation of what's currently in the Medicaid news cycle right now. The brand names involved are Advocacia and Azara, and Advocacia is a benefits enrollment platform, and Azara is a population health and value-based care platform, whatever that means. And they think when they put the two platforms together, it's going to help them ID people that may lose their Medicaid coverage under the new H.R. 1 work requirements. So the Advocacia system, I think, also helps member clay submit application information in like 75 different languages. That's interesting. It also collects some of the needed documentation like income verification, and it will let caseworkers and navigators see where member clay is in the reapplication process. So it's to kind of translate this for you. If health plans, who are the ones who stand to lose the most from Medicaid work requirements, are ever given the ability to hold member hands while they fill out those resubmission applications, they could use this tool like this Azara and Advocacia combo product thing to know who to outreach to and pester a little more each day to get the paperwork done. Hey, did you get the paperwork done? Hey, did you get the we really need that. We really need your PMPM to come in. Did you get the paperwork done? Next up in tech news, item 5 in your Intel report, Maryland's new AI innovation lab to help state agencies adopt and to experiment with tech. So the state of Maryland has announced that it's launching an AI innovation lab to help all of its agencies in the state as they navigate the new AI-driven world. It's going to give agencies a sandbox environment, some new tools, and importantly, the ability to up their security game and identify vulnerabilities in tech systems. The last part is called a red teaming solution, where basically white hat security pros, so good guys, get to act as black hat bad guys. They get to act as hackers to look for weaknesses in state systems. If you've been following the Claude Mythos story, that probably is driving some of this. But the interesting thing is this is all going to be led by Pat McLaughlin, who is the head of the Maryland Benefits Platform, which of course gatekeeps access to safety net services and eligibility systems for things like Medicaid and SNAP. Other things to note in here: Maryland has a partnership with Anthropic. For those of you watching the AI Supremacy Wars, I do think this probably does tie to Mythos, and maybe they're one on the short list who gets access to that. Okay, let's move on to pharmacy news for this week. First up, let's look at this story. Item 7 in your Intel reports: with a $3.2 million grant, rural hospitals may avoid generic drug shortages. I'm not sure yet what to think of this one. It looks like the Civica Foundation, which is part of Civica RX, the manufacturer, and the Helmsley Charitable Trust, for some reason, are giving $3.2 million for a pilot that's going to let some rural hospitals join together and buy cheaper generics. I think this may be an effort to offer an alternative to 340B, which makes sense because manufacturers are not happy with 340B. It may be a revenue-generating device too, because what I'm seeing on the pilot is they're going to charge participating facilities $300 per bed as a one-time fee to get access to, I think, a list of like 70 generic drugs at whatever the preferred pricing thing is here. These drugs include painkillers, blood thinners like heparin, morphine, other things. Overall, the pilots are going to launch in, I think, 9 states: Hawaii, Iowa, Minnesota, Montana, Nebraska, Nevada, North Dakota, South Dakota, and Wyoming. In those 9 states, they're going to touch about 225 rural hospitals and almost 7,000 beds. So doing a quick bit of mental math, I think 7,000 beds times $300, that's like $2.1 million in initial fees. So then we're looking at like a net $1 million investment for whatever it is that Civica and the Helmsley Foundation are trying to do here. I would say let's keep an eye on it. I think we should keep an eye. It seems kind of niche and novel, but maybe not. I do think it makes sense to keep an eye on it. It's interesting to see pharma. It's interesting to see pharma manufacturers getting creative to try to start to limit their exposure on 340B. Next up in item 9 in your Intel report, still on pharmacy news, Maryland HHS expands Medicaid coverage for pharmacist-provided services. I'm sorry, it's Michigan HHS explains. If you've been tracking the last few years, there's been a lot of dialogue in the space about letting pharmacists provide more actual services. There's a lot of thinking behind this, which essentially boils down to pharmacists see patients a lot more than physicians do. But Michigan is now allowing pharmacists to bill through the Medicaid program for immunizations testing, some contraceptive services, some labs, other things. They're going to be able to run some lab tests like COVID and flu, and then prescribe based on those results, like certain antivirals. The pharmacist will have to enroll in state Medicaid provider program. And overall, I don't think this is groundbreaking and shouldn't really shock anyone. It does not really seem like a massive expansion of scope of practice to me, but it might pave the way for a subsequent expansion of scope of practice for pharmacists in the future. Next up, let's look at CMS news. And our, huge news this week, last week, the new CMS guidance that came out on work requirements / community engagement requirements. There's been a lot of talk about this, in my opinion. A lot of it's been deceptive, at best, kind of uninformed. So I want to give a high-level overview for the audience. First up, the rule that came out is the CMS interim final rule. I've got a screenshot of it up on the screen if you want to go look for it. But I'm also putting an analysis of this up on LinkedIn. Hopefully this week we'll see. I think the big headline is it still absolutely clarifies that the only people who are subject to these requirements are those that got in under Medicaid expansion. If you look at the adult group piece of who this applies to, those are all, everybody that you thought was exempt is still exempt. Pregnant mothers, this doesn't apply to. Dual eligible members doesn't apply to. Disabled members doesn't apply to. Those are all still exempt. Those ACA rate cells that plans love, that's who this applies to, which means if you're a member that a plan's getting the revenues off your back through those rate cells, you really weren't as sick anyway, based on everything we know about that population. You're not as poor anyway, based on your income. Otherwise, you would have been in other eligibility groups before all this. You would have gotten in through disabled, pathways or pregnant pathways or dual, all that kind of stuff. So it also spells out the requirement that members that want to keep their health insurance that this applies to, remember, not disabled, not elderly, none of that. They're going to have to do some things for 80 hours a month. So they're going to have to work or go to school or volunteer for 20 hours a week. And if in any 1 month they don't do that, they can reapply later. So it's not like they lose it forever. This rule also turns back on certain things that got suspended in 2024 related to eligibility applications and timeliness and renewals. And the thing that most blue states are really up in arms about is the medical frailty piece from this rule. If you watch what was happening in states like California and others who are opposed to work requirements, put another way, those looking for a way to disobey what is now federal law, they were hoping they could just slap on a medically frail diagnosis to all the 27-year-old otherwise healthy bartenders and keep those sweet, sweet ACA rate cells flowing for all the Medicaid members who probably don't even care or probably don't even know they've got a Molina card in their pocket. Remember, this is like 90 to 100% federal money, so of course plans love it, and of course states that use Medicaid to bloat their budgets love it. So in addition to having according to the rule now, in addition to having a qualified diagnosis, which I think there's like 300 pages of diagnoses in the rule, that condition also must exist in the real world. You can't just have slapped it on there, and they have to actually be significantly impaired from complying with the federal law to continue to get the taxpayer-funded benefits. So CMS even goes as far as to say as which conditions are more or less likely to meet the standard, and then they say you need to use data from claims and encounter systems or other screeners and assessment tools to go ahead and proactively flag who you think are, might be trying to get in this medically frail piece that needs special exemptions. If you stick around for the interview with Sebastian, you'll hear from an actual behavioral health provider how they're planning on getting their members that need these exemptions, the types of documentation and assessments, the tools they're already using to do that, and how they're going to do that for this Medicaid work requirements piece. But just to try to put it all together for you, the vast majority of actually medically frail people are not in the ACA rate cells to begin with. They're not in the ones that this is focused on. So states and plans want to protect these ACA rate cells because it's the most profitable one. Remember, the majority of this is 90 to 100% federal money. The majority of this is members that have far less severe needs than who we all think of when we think of Medicaid members, the ones that we trot out, those ABD, age-blind disabled members. And some states were hoping to use a trick of slapping on a diagnosis code to subvert the federal law. So CMS in its guidance has said that's not enough. And now you're going to hear nothing but an unending stream of people mischaracterizing the guidance. Like I said, I'm trying to get a detailed analysis out on LinkedIn with screenshots from the rule and from the parts of SSA and CFR to try to help people that do want to actually know what's going on. So look for that coming off my LinkedIn profile this week. For now, let's do a couple quick state news items. As always, don't forget to check out the map. You can see all the states that are covered in the Intel report for this week. I only get to cover a few here on the show. First up is Colorado, item 14. Sunshine Rides suspends Medicaid non-emergency transportation nearby. Plans full suspension ahead of unsustainable state cuts. So let's dig in a little bit more, see what we're really talking about. So what we're really looking at here is Sunshine Rides, which is the largest non-emergency medical transportation provider in Colorado for Medicaid, said, we're pulling out of these 4 service areas because we just can't accept the lower rates that the state legislature recently passed. Now, this company may eat their words. We'll see. They get revenues, a big part of their revenues from the 22,000 Medicaid members that are hopping on their vehicles. And Medicaid accounts right now for this one company for 600 trips per day. So now this comes at a time. Of course, there's other parts of the story. This comes at a time that recent state investigations found $25 million in fraud for non-emergency transportation. I'm sure not all of that was for Sunshine Rides, I don't think. But a couple of other facts in the investigation. NEMT has been under scrutiny in Colorado for about 3 years now because they found companies would drive hundreds of unnecessary miles, like out of the way, to get more mileage. They would load up cars with multiple patients and use cash or drug kickback schemes. So in addition to the flat-out fraud, there was also a billing error that went on for years that led to the state paying providers like Sunshine 10 times more than they should have. So instead of like $65, they get $665 for the ride. That's being corrected, and that's going to save the state about $60 million. So if you look at it in aggregate over about 5 years, from 2019 to 2024, NEMT spending went from $34 million in the state to $280 million. So lawmakers looked at all this and said, look, we got to do something. We got to cut rates. And they made the decision to cut them by 50% on per trip rates. So Sunshine has not really said how much they got overpaid, as far as I know. So they're just saying, the new rate is too low. And ultimately, the latest reduction does take trip payments down from $12 and mileage, take down to $12, and then mileage for $280 per mile. So again, we'll see how this turns out. I seriously doubt that the state will ever get any of the money at overpaid vendors like Sunshine, but I'm sure it's going to get an earful about how the new rates are too low. Now let's look at item 18 in your Intel report. This is states agree to share data with DOJ to fight Medicaid fraud. This particular story is really focused on Indiana, but it's broader than that. Indiana is just the first state to participate in this pilot. That's going to send data back to CMS and Oracle as part of a statewide fraud analysis. It looks like I think maybe Ohio is interested in playing along with this pilot. And former CMS Seema Verma, also with Indiana ties, who now is in leadership position at Oracle, is in the article talking about that company's role in the new program. Of course, there's not a lot of new information on this pilot yet, but it seems to be a natural sort of outcropping of the recent efforts we've seen CMS execute to finally start to deal with the massive fraud. Most likely we'll continue to see blue states resist and red states volunteer. One more quick story in state news. Item 26 in Nevada, they paused Medicaid enrollments and hospice licensing during fraud probe. So Nevada announced last week it is pausing new provider enrollments and licensing for hospice and home health providers for at least 6 months. This, of course, echoes what we've seen in Minnesota and California, except in the case of Nevada, it looks like they may have decided to be a little more proactive before CMS pauses billions in funding. According to state officials, the pause is going to be for 6 months, and if anyone needs an exception to this, they're going to need to prove that they are critical to the safety net and rural and underserved communities. One more quick item in reform news. This is item 31 in your Intel report. Federal data reveal top earners in Medicaid's 403% ABA spending surge. It's kind of a pickup from a story. I think there was a New York Times story maybe 2 weeks ago that we covered that showed the role of private equity in the ABA spending surge. If you're not familiar, there's new analysis on Medicaid payments for applied behavioral health analysis for autism for those members' needs, and spending has absolutely skyrocketed. And there's a lot of variation in what states will spend on this, so something's going on there. What I like about this particular article this week is it starts to name names, provider names, and we see that groups like Centria Healthcare in Farmington, Michigan, that one group got 4% of all Medicaid spending nationally. on these services in 2024. We also see that ADS kids in Salt Lake City is not far behind. They got 3.4% of all national ABA spending. This article has other things in it, like the growth of providers themselves. We saw 346% emerge in providers of this. The study looked at nearly 200,000 records in their data analysis, and guess what? The top 4 providers, which are this Centria Healthcare, ABS Kids Lighthouse, Autism Centers, and HelpBridge, yep, they are all backed by private equity. Of the top 20 all-time highest ABA services providers, I think like 5 are based in Indiana. There's a lot of other really good data points in this article. I suggest you check it out. It's item 31 in your Intel report if you're tracking the ABA spending story. Let's take a quick gander at the fraud map for this week. Kind of a slow week. Only 79 million of your tax dollars were stolen from you and from members who were supposed to get services using this money. In this last week, at least what was reported, what was identified. Remember, there's always so much more. The bigger ones are in Arizona and Minnesota and Ohio. Don't forget, we have literally dozens of these individual stories each week. We pull together the whole story. We summarize it, highlight it, put it in your Intel report if you want to check them out. I'll call out just a few of those for the self-delusional ilk in our audience that think fraud is not real in the Medicaid program. Or it's not a big deal, or it's all being politicized. First, let's look at item 32. We've got an Arizona couple, the Vaughn, I don't know how to say that name right, and Alexis Curry, a couple here, like a romantic couple. They're going to prison over their fraud in Arizona. They stole $12 million that exploited vulnerable Medicaid members who needed help with their drug addiction. This is, of course, related to the massive multi-billion-dollar sober homes fraud that targeted Native Americans in that state. We're finally starting to see some convictions. They were first arrested in 2023, and they are now each the proud owners of a multi-year prison sentence. Now let's look at another one. Let's jump on over to Kentucky. Item 37 in your Intel report, Addiction Recovery Care founder Tim Robinson indicted in federal court. Mr. Robinson has been indicted on money laundering charges, wire fraud, and also on Medicaid fraud. He's under investigation for that too. In the Medicaid part of his crimes, former employees have said that his organization billed Medicaid for services that were never provided. His company, ARC, at one time was the largest drug addiction treatment company in the state. They operated more than 40 centers. They've been under the watchful eye of the FBI since the summer of 2024. Robinson has been sued in other venues for selling IRS tax credits. I didn't realize you could do that over and over, like to multiple people. And there's some reason to believe that this was to help out with his company needing to pay $28 million to a DOJ settlement over other Medicaid frauds. Let's do one more fraud story. This is item 38 in your Intel report. Comes from Louisiana. This is where we meet 2 lovely ladies from Shreveport, and they've been charged with defrauding Medicaid and SNAP. We meet Tanisha Bowman and Julia Caesar, both of Shreveport, Louisiana. Julia actually used to work for the state, for the Louisiana Department of Health. She helped her friend, I think it was, she helped Tanisha get her Medicaid benefits illegally turned back on. It was illegal because she lied about her marital status and her household income. Julia used the Medicaid agency's phone system to help her friend falsify public records and get those Medicaid benefits for her and her kiddos turned back on. Funny enough, Tanisha is married to another government worker who works for the city of Shreveport. So we have 2 different government workers tied to a Medicaid benefits fraud working for 2 different levels of government. All told, Tanisha stole about $120,000 in benefits from Medicaid and about $35,000 in benefits from SNAP. I'll let you check out all the rest of the details in the dozens of fraud stories that were reported this last week in your Intel report. Now let's hop into this week's guest segment. So excited for our guest for this week, and then after we do the guest segment, we'll come back and we'll do Job Hunter and other things and close out. And up next, we're talking with a dear old friend, Sebastian. Sebastian, for folks that aren't familiar with you or your work, please give a quick self-intro, and then I really look forward to catching up and getting your thoughts on these news items. Go ahead.
Good talking to you, Clay. I'm currently Director of Behavioral Health Outpatient Services at Kenneth Young Center. Kenneth Young Center is a nonprofit organization. We're serving the Northwest County, Chicagoland area. We provide behavioral health prevention, intervention, recovery services to youth, adults, seniors. This year, we're celebrating our 55th year of operation. We're supported through a mix of grants, endowments, commercial Medicaid and Medicare billing. Myself, I've been doing the work in behavioral health and government sponsored programs for over 25 years now. I started as a frontline clinician uh, in community mental health. I supervised a crisis response and stabilization program for youth, directed managed care coordination programs for integrated care, HCBS, dual eligible, long term care, and ACA marketplace products. I assisted with the creation and deployment of outreach work teams specialized and trained in responding to teen trends, and established one of the nation's first violence prevention community support teams, which is 1115 waiver billing for Medicaid. And with the exception of a year where I did led the emergency room at HCA Mission Hospital in Asheville, North Carolina. All of my experience has been in the Chicagoland area. Great to be here with you.
It's great to be here. I have to start out with how we met. I'm pretty sure it was the big COVID Zoom conference we did and the happy hours. Is that right? Like, I think you joined a happy hour after one of those. I think that's right.
That's correct.
Yeah.
We did
Yeah.
quite a few happy hours. And that's
Right.
when you were making the homemade wine.
Homemade wine. That's right. Yeah. For folks that don't know, in June of 2020, we did a 4-day, all day Zoom conference all about COVID. It's like, hey, what's going on in your state or what's going on in your plan or whatever. Sebastian showed up to one of those and we're like, hey, once we're done with these 8-hour sessions of Zoom, we're going to do happy hours. And we did happy hours and I was making fig wine and all that kind of stuff. And then we started a kind of a happy hour crew after that, where we got together about once a month, and you did those for a while too. Kind of a special time. I think we all kind of helped each other get through. So anyway, so good to see.
I was always stumped by the questions
That's
because
right. We did the
you had
questions.
some zingers.
That's right. I forgot about that. I would send out questions ahead of time, and if you couldn't make it, you would send in answers. Otherwise, you would answer them, and you would always send in yours if you couldn't make it. I totally forgot about the questions. Yeah.
They were full of snark. So that really hasn't changed.
Right, right, right. All right, let's get your take on these news items. So, let me pull the ones you picked up. First one is new federal rule tightens medical exemptions for Medicaid work requirements. I'll just do a quick bit of setup and then I want to hear your take. So, I mean, basically, I think last week CMS puts out detailed rules of, okay, here's how we want you guys to walk out work requirements. And one of the big surprises was states are not going to be allowed to really kind of define their way out of this with medical frailty, that kind of stuff. I think that was a big shock to a lot of people. If I remember right from the rule itself, there's like 300 pages of diagnosis codes, but they're saying you can't just do diagnosis codes. You also have to somehow prove it's actually limiting your functionality. Anyway, I don't know. What do you want to talk about on this one?
Unfortunately, the agenda's clear. It's the reverse Robin Hood. We're going to steal from the poor and give to the filthy rich. We at this point, with all the organizations that I've been in, especially currently with KYC, all we've had to do is have someone in treatment. We provide a letter saying, hey, they're currently in treatment, and that would be enough to suffice. The new Medicaid work reporting requirements, and I couldn't sum it up any better than Joan Alker from Georgetown in one of your recent shows, where she said Medicaid work reporting requirements will not support work. Well, but they will increase reporting requirements. So yet another high bar, another flaming hoop that the poorest of the poor have to kind of jump through to be able to have just a living subsistence and have access to healthcare. What we're doing at KYC, Kenneth Young Center, is in addition to those diagnosis codes, we're looking at using a standard tool that we have in our toolbook, the DLA 20, daily living activities. Basically, it's used to determine whether or not someone is able to function across 20 different life areas: hygiene, social skills, work. We use it to track progress and determine service arrangements. But that should be enough to demonstrate that you know the majority of our folks who are receiving services cannot perform 80 hours of work-related activities every month just to maintain their benefits.
Got it. So as the service provider, you guys have a tool that you can use to meet that part that says it's not just a diagnosis. Here's a functional assessment piece of it. And I think I heard you say, like used to, you could just send a letter that said that, but I guess now you'll have to provide additional information. But so, I mean, you guys will be able to help out your book of business or patients or whatever. Um, and I guess that's where this is going to land with some sort of service provider is going to have to do this, right? For a member to keep it.
I'm hoping that the state will kind of align or support us in this. Um, in many instances, the state can kind of set the standards, and all providers in the state can say, okay, this is what we're doing to meet that standard. We're hoping that they will do that because again, the DLA 20 is a tool that's required for Medicaid billing in the first place. So if it's already there, why not use it? Um, I'm concerned that we, have the risk that if we're providing too much information to the feds, that one, um, clients and families will be resistant to seek treatment because their PHI is out there, and then two, when they do have that information, what else are they going to do to call back money or reduce eligibility or look at other areas to limit those benefits.
Thank you. Anything else on this story?
Um, no, it's depressing, but we got to keep moving.
The next one you want to cover was in Connecticut. There's a community health worker still waiting for Medicaid support. So going back 3 years ago, legislature there passed a law to pay for CHWs, but the state hasn't yet funded the program. What do you want to talk about on this one?
Community health workers serve a very vital function in the uh, community in terms of recovery and supports. I think some years ago it was estimated that 70% of the people who recover from a mental illness or an addiction are natural recoverers. So they don't necessarily seek any formal treatment program. So they don't have contact with a medical or a professional. But those with lived experience, they have a lot to offer. I know that in Illinois, we're one of 20 states that do cover community health workers, and we're able to bill Medicaid for ancillary services. Over the years, I've worked with parent mentors, healthcare navigators, engagement specialists, recovery coaches, outreach workers, and case managers who are in that lived experience space. And I've had some recent conversations too with my colleagues and staff about non-clinical and clinical staff. What I found is that non-clinical staff can operate in a number of different spaces that professionals and clinicals cannot even begin to approach. One specific area is in violence prevention. The violence prevention community started with the outreach workers who, you know, are or were former gang members, who, were returning citizens, who were shooters, those who have lived the life that they can provide the services to get others who are actively involved in community violence to put the guns down, and choose some other different types of choices. And of course, as we recognize these peer supports and those with lived experiences, once you professionalize that community, they have options for earning as well. So they would definitely meet the Medicaid working requirements and turn
Right.
around to being independent, citizens in our communities.
If we could just get them paid in Connecticut,
That would be a wonderful,
that would be helpful, right?
yes.
I mean, I still wonder, like, why are these joker? I haven't dug down into this particular story, but I mean, they just haven't set aside dedicated monies, I guess, for this.
Do you think it's a result, or if it's correlated to the fact that they pretty much kicked out, managed care? I know they use, I think it's an ASO model to reimburse. And here in the state of Illinois, there's, MCOs do recognize, peer workers, for Medicaid coverage. I think in that case, they're looking at grant dollars to be able to
Right.
support peer support workers.
I mean, I guess it certainly could be. I mean, I think Connecticut hasn't had managed care for a while, but I guess you're saying if they did have managed care, it would be easier to move the money to these folks and just kind of fund it as part of everything that we fund in managed care versus cobbling together. I mean, I could certainly see that. Um, yeah, I think I want to dig a little bit deeper into this one. Maybe I'm sure this will come up again, even if it's just next year that they're still not getting paid. Let's talk about item six. It was 16 in this week's Intel report. I think this is the last one you want to cover. This down in Florida, Medicaid termination letters leave South Florida behavioral health patients and therapists in limbo. Looks like, and we see this kind of unfortunately often, but you get these unexpected letters saying, your coverage is either your provider's out or you're not covered anymore. We've got several providers saying they've got 30 days. They're not really being told why. Looks like this touches some ABA stuff as well. What do you want to talk about with this one?
Well, anytime the feds, send out notification, again, those 30-day termination letters without any audits, no notice, there is, usually an agenda related to, trying to reduce the number of folks who are able to bill Medicaid for these services. Um, Medicaid dollars are safe. uh, you know, we need this to provide funding or coverage for those below the poverty level, and ideally these dollars are spent for diagnostics, preventive care, and early intervention, so that we don't have the catastrophic costs, hospitalizations, transplants, long-term care. Um, but over the years, the feds have kind of targeted these niche providers. ABA therapy, autism therapy has kind of exploded in the last, I would say, probably 5 to 7 years in terms of
Mhm.
diagnosis, in terms of those who are identified as needing the services. And so this is kind of a population that's um, kind of ripe for not only being targeted to kind of bring back money, but also some potential areas of fraud, waste, and abuse.
Yeah, I mean, there's been a lot particularly on the ABA piece, a lot on the role of private equity in that surge out in the news the last couple of, I mean, that's kind of the macro piece, but like to the point that you're making, we also have a bunch of providers that don't know what's going to happen and their patients. I think we see similar things I think I've seen similar things over the years in Colorado and Ohio, just kind of all of a sudden the rug's pulled out from underneath. Um, Let me ask you a couple of questions before we close out this. I want to, since we are fortunate enough to have an actual provider on the show. That's awesome. Thank you. I would like to. So I got two questions for you from that perspective. How have you seen just behavioral health, the practice, the profession, the needs, however you want to think about that? How have you seen that change over the course of your career? And that's question one, just however you want to describe that. And then question two is, what advice or encouragement would you give your peers in some other part of the nation right now? To the Sebastian in California or New York or whatever, like you're all kind of going through a similar thing. Like, what advice would you give them? But first question is, how have you seen behavioral health? I know that's a big topic, but how have you seen it change or evolve over the course of your career?
Well, one of the biggest changes that I've seen, that it's become less of a specialty kind of unto itself. Um, Part of the challenge that I've had over the years is, for clinicians and systems to recognize, behavioral
Hmm.
health as a specialty area, just like
Hmm.
optometry or urology, you pick it. Um, but what we're also finding with behavioral health is that behavioral health is more of an integrated function. Behavioral health touches on the social drivers of health. It touches on, actual physical health. The life expectancy is much lower for those who have physical problems, but also have co-occurring mental health disorders. And so I think the recognition that behavioral health is important, and oftentimes, just as important as physical health, makes a huge difference in terms of our delivery. Now, as service providers, we can't go back to the siloing piece. We have to work with, other specialists. We have to work with primary care. We have to work with systems so that we become fully integrated in, treating our communities.
Right. That makes a lot of sense. Thank you. What about the second question? What advice or tips or encouragement would you give your peer that may also be listening in some other part of the country or whatever?
Well, I think one major area, especially in the realm of behavioral health, is that we treat the work that we do, as a science, as an intervention. I'm still hearing from clinicians who, um, spend their 53 minutes of, in a session, kind of letting their clients and family drive the session. So whereas, we do screenings, we do assessments, we sit down and do service plans, with the family, we don't often follow these maps. And these are the maps that help our families and clients get better. The whole idea for me is to work myself out of a job. If no one has any mental illness or doesn't need any long-term care, then I figure our work is done. But the challenge is that, we work with clients and families to get them to recognize that the actual work is done outside the session. It's done outside the clinic. It's done in the community. It's done with your peers. It's done with the relationships. And we're just there to help you kind of navigate the trauma, navigate the obstacles, and to find new opportunities to get and feel better.
Thank you. All right, now you got to answer the question on a scale of 1 to 10. And I mean, for folks listening, of all people, especially in a small group of people that could really answer this with a lot of, he's seen me again over multiple happy hours over the years. On a scale of 1 to 10, how full of it is Clay Ferris?
I will say 9.5.
Yes.
And I'll say 9.5 because, you put in the work in. You're really out front, making sure that people understand all of the different changes, with Medicaid, across the spectrum, about payment sources, about how important it is for us to talk and to communicate and to collaborate. Because again, if we do these things in silos, that's how we get steamrolled. Because this state or this community, this township doesn't know what someone else is doing, and why keep recreating the wheel and just being in a long line getting steamrolled. It's easier to push back as a collective than it is, as a silo.
Thank you. Thanks for being here today.
Thank you.
Just a quick reminder, be checking out your intel reports for all the jobs that the research team is putting in there for you that we think you might be interested in. You can, if you want to pause on the screen real quick, if you're checking this out recorded, you can kind of see the types of stuff, but all that will be in your intel report if you're looking for your next role. For now, let's do grab bag, and we will start out with acronym of the day. So acronym of the day is ADL. That's activities of daily living. That's pretty important to, relating to what I was talking about for the new work requirements. So if you are subject to the new work requirements, which the vast majority of Medicaid members are not, but if you are in it and you need an exemption for being medically frail, so if you're not able to work or volunteer or go to school, in addition to that diagnosis, you're going to have to prove that that diagnosis is having an impact on your ability to meet the requirements. And one of the ways would be things like looking at your activities of daily living, that kind of stuff. If you're new to our space, this is one of those terms that sounds kind of simple, but it really does a lot of heavy lifting in Medicaid. So ADLs, these are like the basic self-care tasks that most of us do without thinking. These are bathing and dressing and eating and getting to the toilet and moving from a bed to a chair, just getting around. They matter because they're one of the strongest measuring sticks we have for a person's actual needs, kind of the gaps between the supports they have and what they're needing. So this has been used historically for deciding whether or not somebody gets on a long-term care waiver, home and community-based services, whether they count as medically frail. Usually you'll have people go in the home and do these pretty extensive assessments, whether that's a vendor or AAAs will often do this type of stuff. So ADLs drive eligibility and always have, and they'll probably have a role in this new work requirements thing. They drive which services you get. And hopefully we see some improvements on some things that can drive outcome measures. So anyway, the acronym of the day for this week is ADL. You should also see that in your Intel reports. And like I said, the team, if you want to pause, if you're watching the recording, the team's been putting together these amazing infographics for all of the acronyms. All right, let's do Mission Possible, where each and every week I give you a small mission that is not related to work, to where you can do some things that have nothing to do with work, hopefully. This is coffee break, so actual break. That doesn't mean just drink some coffee while you work. So if you're a coffee drinker, which I think the vast majority of us are, I do believe that coffee is the number one addictive drug in the world. It used to be, and I'm sure it still is. If you're a coffee drinker, take time to actually sit down and enjoy a cup, whether that's today as you finish up your work week on this wonderful Friday or this weekend, but just sit down and enjoy it. Think about something besides work, or think about nothing. How about that? But this week's Mission Possible is coffee break. Take one. Tea is also acceptable if you're not a coffee drinker. And that's it for this week's Medicaid On The Brain. I hope this has been helpful for you to keep up with all the things that are going on. Thank you for all the things that you do to make the Medicaid world a better space. Until next week, I'm Clay Ferris. I'll see you on next week's episode of Medicaid On The Brain.